Good morning, all. At the outset, I would like to thank Dr. Gija and KSOS for giving me this opportunity. Ocular hypertension is defined as IOP greater than or equal to 21 millimeter mercury with applanation tonometer in 2 or more occasions with normal visual field, normal optic disc, open angles, and no ocular or systemic cause of increased IOP. Ocular hypertension occurs in 4 to 10% of population over age 40 and is 10 to 15 times greater prevalence than POAG. The high prevalence of ocular hypertension and its progression to POAG raises several questions. How often should ocular hypertensives be examined? What diagnostic tests should be performed? And can we identify at high risk and low risk for developing POAG? And how many patients will develop visual limitations? And finally, which patients might benefit from early preventive treatment? Ocular hypertension treatment study evaluate the safety and efficacy of topical ocular hypertensive medications in delaying or preventing the development of POAG in individuals with elevated IOP. It also identified the baseline demographic and clinical factors that predict which participants will develop POAG. The entry criteria was age 40 to 80 years with normal visual fields, normal optic disc, and untreated IOP of greater than or equal to 24 millimeter and less than or equal to 32 millimeter in one eye, and greater than or equal to 21 millimeter and less than or equal to 32 millimeter in the fellow eye. So it was phase 1 was conducted from Feb 1994 to June 2002, and patients were randomized to medication group, and IOP was lowered to 20% and equal or less than 24 millimeter. And patients were treated with the anti-glaucoma medications according to the clinician's preference. And observation group, there was no treatment given, and the patients were monitored with 6 monthly visual fields and annual optic disc photos. And reproducible abnormalities noted when there is 3 consecutive visual field abnormalities and or 2 consecutive sets of optic disc photographs abnormality. The summary of phase 1 shows that at the end of 60 months, the cumulative frequency of developing POAG in medication was 4.4%, and in observation group it was 9.5%. So it provided clear evidence of treatment efficacy. Phase 1 did not indicate when medication should begin and if all patients should receive early medication, and is there any penalty for delaying medication. So phase 2 trial was conducted. It was done from June 2002 to March 2009. Medication patients were continued on medication while the observation patients were started on medication. So it was the delayed treatment group. Delaying treatment of OST increased the cumulative incidence of POAG at 13 years, and there are more eyes with structural and functional damage, more participants with bilateral disease, and there was shorter time to develop POAG, and waiting does not have a large effect on mean deviation and pattern standard deviation within 5 years of developing POAG. So second phase helps to draw conclusion about the management of patients with OST. Early medical treatment decreased the cumulative incidence of POAG. The absolute effect was seen in high-risk individuals with little benefit of early treatment in individuals with low risk. Another study was the European glaucoma prevention study. There was no statistically significant difference between dorzolamide treated patients and placebo group in reducing the incidence of POAG in ocular hypertension. Based on the OSTS and EGPS study, baseline predictive factors were identified. It include age, IOP, central corneal thickness, vertical cup disc ratio, and pattern standard deviation. So for every 1 millimeter rise of IOP, there was 10% increased risk for POAG. And with increasing age, there was increased risk. Black race people had thinner central corneal thickness, increased cup disc ratio, and increased IOP, which made them more prone for POAG. In OSTS study, there was no evidence for family history of glaucoma, but in Rotterdam study and Barbados study identify family history as a risk factor. Increased cup disc ratio was an independent risk factor for POAG. A 0.1 increase in vertical cup disc ratio, there was a 19% higher chance for open angle glaucoma, and 0.2 decibel increase of pattern standard deviation was associated with 13% risk. Central corneal thickness is a strong and independent risk factor for glaucoma progression. If central corneal thickness is less than 555 microns, the annual risk was 3.4%. But in Indian population, the normal central corneal thickness is between 520 to 525 microns. So if the central corneal thickness is less than 500 microns, it is considered to be more prone for POAG. And risk calculators are present online. It is based on OSTS and EPGS study. And we have to write enter the age, IOP, central corneal thickness, pattern standard deviation, and vertical cup disc ratio. It calculates the probability of conversion to POAG in 5 years. And level of risk over 5 years, if it is less than 5%, then it's better to observe and re-evaluate every 12 months. If the risk is moderate, that is 5 to 15%, consider treatment, or you can keep the patient under observation. If the risk is more than 15%, treat the patient. So treatment is needed when the patient is on high risk. Such patients need more frequent examinations and early treatment. Treatment is depending on the patient age, health status, life expectancy, and personal preference. IOP above 30 millimeters is better to treat. IOP in the mid to upper 20s with risk factors like family history, thin central corneal thickness, increased cup disc ratio, etc. is better to treat. And young patients, one-eyed patients, unreliable patients, patients who cannot do reliable visual fields, or if there is any optitis cannot be visualized, or patients who prefers to be treated, and if there is any history of retinal vascular occlusion, is better to treat. Observation is indicated if the patient is older age with shorter life expectancy, borderline elevated IOP, thick central corneal thickness, if there is an inability to tolerate treatment, and if patient prefer against treatment, is better to observe. We discuss a case, a 54-year-old male with IOP 28 to 26, with central corneal thickness 534, with normal perimetry and ocytry, but with family history of glaucoma. I think it's better to treat the patient. Treatment can be medically managed, or selective laser trabeculoplasty is another modality for treatment in case of OST. Thank you.